Má byrja á að segja það? Okay. Góðan daginn og velkomin á þennan fyrirlestur, þannig mikilvæga fyrirlestur sem við erum frá að hlýða á. Mér finnst mjög gaman að bjóða ykkur velkomin hérna og ég vona að það hefur flest heyrst í henni á hjúkrun 2025 í síðustu viku. Það var mjög flottur fyrirlesturinn hjá henni Simone þá. Hún að fjalla mikilvægt málefni sem samráð við ákvarðanatöku heilbrigðisþjónustu, sem eitthvað sem við þurfum að fara að huga í auknum mæli að. Við höfum vissulega skrifið ákveðin skref í því, en þurfum að fara að gera meira af því. Og núna síbreytilegu umhverfi heilbrigðiskerfisins alltaf mikilvægara að heyra sjónarmið bæði sjúklingan okkar og ættingjana þeirra, því að það mun bara auka gæði þjónustunnar og heilsulæsi sjúklinga og árangur meðferða. Þannig að það eitthvað sem við ættum alla huga vel að. Hún Simone komin til okkur á Noregi og það mjög gott að fá hana hér. Hún doktorsmentuð á þessu sviði og hefur mikla reynslu af því að bæði vísindahliðinni og klínísku hliðinni og að samþætta þessa tvo þætti saman í þjónustu við sjúklinga. Hún starfar á Sérstakur sem stærsta heilbrigðissvæði Noregs sem það bil 3 milljón íbúa. Þannig að hún mjög mikla reynslu á stóru flækjustig í þessum málefnum. Þannig að það gott fyrir okkur að fá hennar þekkingu á þessu í þessari vegferð sem að Landspítalinn fer að leggja í. Við Brynja erum búin að ákveða það að þetta verði eitthvað sem við ætlum að innleiða hér þó að verði fyrir það síðar. En við hlökkum til að heyra hennar reynslu og fá innblástur í þessa mikilvægu nálgun á þessu verkefni. So now it's my great pleasure to welcome Dr. Simone Kienlin. Right? Yep. We are truly honored to have you here in Iceland, and we look forward to your insights and your inspiration. Welcome.
Thank you so much. Thank you very much for the introduction. So yes, my name is Simone Kienlin. I am working at the Regional Health Authority in Norway, in the southeastern Regional Health Authority. And we serve about half of the population in our health region. So to give you some more insights, I know you don't have this kind of authority in Iceland, but it's the authority who owns all the hospital trusts in Norway. So there, I'm so lucky that I'm able to work with shared decision-making, health literacy, and health communication, and I'm going to share some insights with you from our work there today. But first, I would like to start to show you a small extraction from a doctor-patient consultation I saw some months ago. In this consultation, we had a doctor. It could have been a nurse, other kinds of healthcare professional, but this time it was a doctor. And he said, I don't know if you have thought about this yourself. They were going to talk about different options and about making a decision. Then the patient answered, I just want whatever is best. And where the doctor again answered, the best treatment is the one that fits you the best. So what does it mean when healthcare providers express something like this? What does it mean for the patient? What does it mean for the healthcare system? I think that this is an acknowledgement that decisions cannot be made on knowledge alone. That value judgments, value and preferences are always part of it, either implicit or explicit. So in other words, it's not possible to find the best treatment for our individual patient without knowing this patient's priorities and individual values and preferences, how they weigh the different pros and cons against each other. So here we have a doctor which has recognized this and understands this and wants to involve the patient in the decision. And as you know, to practice evidence-based medicine, evidence-based practice is about integrating knowledge from you as healthcare providers, from the best available evidence, and from the patient themselves. So we have often asked ourselves, what is the key to really succeed with patient involvement? Is it that the doctor or the nurse gives a little bit more information, that they maybe use teachback, that they provide numbers in a way that the patient actually can understand and act on the information we are giving? Is it that he says that he works according to a guideline, a national guideline? Or what is the key? And we have noticed, actually, one of the keys is if we see this kind of attitude, if we see healthcare providers who really share this kind of attitude, that me as a healthcare provider, I don't know what the best treatment is for you as an individual, because that's why we have to share this decision and talk about this decision together. So I think this is one of the keys to succeed with really to working evidence-based and having an evidence-based healthcare. And of course, a part of this is the concept of shared decision-making. So shared decision-making is about the patient and healthcare providers, and it's about making the best individual decisions for each patient. Using the best available evidence. Could we maybe turn off the light a little bit? Is it possible? I think it's getting, the pictures is, yeah. So using the best available evidence when we present all the available and justifiable options when we make healthcare decisions with our patients. Maybe it's better already, or?
Stendur ekki myndarsýning eitt eða eitthvað laus?
Oh, this better, right? Okay, but don't fall asleep. Now it's getting, okay. I will just go on and I can try to fix it. Okay, so now this jumped a bit, but so we know that we get knowledge from the healthcare professionals, and we get patients that come with their own values and preferences. And some may say that this is good enough, but then we still are sitting on the information monopoly. And this should not be the case, because we should also recognize that we are not the only ones sitting on the important knowledge into this decision, but of course the patients also have important knowledge to bring into this discussion about making decisions. So we have to recognize that patients can make medical decisions, but of course it's our responsibility as healthcare professionals to provide the information in a way that they are able to understand and apply this kind of information to make an informed decision. So this is the concept of shared decision making. So I would like to share a timeline with you, what happened in Norway the last 10 years. So first, in about 2012, the term samvalg was launched, and it was a big effort also from patient organizations and patient user representatives. Here we can see in a journal, Dagens Medicin, he's a patient representative talking about the healthcare service, and the patient should be in the center of this. He's talking to the board of the regional health authority. After that, the term was included in a lot of different white papers in Norway over several years. And the ministry's assignment documents, where they assigned us in the health authorities to work more and make evidence-based patient information better, and also develop so-called patient decision aids and work with implementation of shared decision-making. We wrote a paper on the status of shared decision-making for a big conference, international conference of shared decision-making in 2017. We were very optimistic that this is going to go fast in Norway, because now we have the political support, we have the patients on board, but actually we were a bit disappointed that the implementation didn't go so fast as we thought. So in 2020, our health minister said that samvalg skal være det normale. Shared decision-making should be the new normal, and that was really helped our implementation efforts as well. And so when we wrote a new status from Norway, we were we saw that things were improving, but of course we still have a lot to work with, and I'm giving you some insights about that. And today we are here that we have launched a regional strategy for implementing shared decision making in our health regions, and the other regions have also similar, not as big as a plan as we have, but they also have some strategies for that. So when we launched the term shared decision, samvalg in 2012, we also made a Norwegian definition, which was very important because we want to have the same definition when we work and try to implement something, because it makes it easier both for the implementation, also when we want to measure it, to have a baseline measurement, what kind of definition is important then. So in Norway, we have this one. In shared decision making, the patient and healthcare professionals should collaborate to make decisions. And it is, of course, not only about treatment, but also diagnosis and follow-up. And patients should be included in the extent that they desire. And the patient should be supported in evaluating the option based on the best available evidence of benefits and harms, and also be supported in exploring their own values and preferences. So this definition is in one of our white papers. So I looked a little bit into what kind of strategies you have here in Iceland, and I saw that you have one strategy where shared decision making is not explicitly mentioned. However, the word informed decisions is mentioned. And this is, of course, very, very good, because the goal of the shared decision making process is that patients can make informed decisions. So we define an informed decision that is one where patients know all the options, the justifiable and available options, of course, not every option in the world, but the ones who we give in the specialist or in the healthcare system in the country, that they understand the consequences of each option, and that they act according to their own values and preferences. So, an informed decision can be made by a patient when they get good information. Maybe you have some information on the hospital's website they can read about, and then they can make an informed decision. Or we can have a shared decision-making process to reach at an informed decision. So both are possible. So when we have a healthcare problem, we have different alternatives, different options. This applies that we can use shared decision-making with our patient, and it can, of course, be in a lot of different medical and healthcare problems. So yesterday I also had a lecture the whole day for clinical nurse specialists, and we got a lot of different medical problems which we talked about where shared decision-making is relevant where you work. And this could, of course, be choosing contraception. It could be early-stage breast cancer, to choose mastectomy or breast-conserving therapy. These are big decisions. It could also be in a lot of different small decisions, all where we have different options and where there are different benefits and harms affecting the patient. So why do we want to implement shared decision-making? There are several reasons for that. It's a legal right for all patients, and we know that most patients want to know about the different options. They prefer to have a more active role in decisions, and when we look at the research, this is just growing. People tend to want more information and be more active involved. We know that it can reduce overtreatment, and I think that's a problem we now have in a lot of Western countries, actually. It can contribute to more sustainable healthcare system and lead to better and more appropriate use of resources. And that's also a very good argument for the implementation. Additionally, we have some documented effects about shared decision-making and the use of patient decision aids. So we know that patients, they get increased knowledge about the different options if they're involved in shared decision-making. They have a better understanding and also about the risks associated with the different options. They have been more involved, greater involvement, and they have less uncertainty about their own values and preferences, and less feeling of being uninformed. And this is the last one here, the feeling of being uninformed, that the information hasn't been good enough. This is a problem we have in Norway, actually, that people, when patients complain about treatments, this is often also the case, that they feel that they haven't been informed well enough. So shared decision making could be one target towards that as well. Okay, so we have, this is Norway, here we have the Southeastern Health Region, and we have a regional development plan towards 2040, and based on that, we have made 2 strategies, one for implementing shared decision making, which I'm going to tell you a little bit more about, and we have a totally new launching about a regional strategy for strengthening the health literacy in Norway, and shared decision making is also included in this. So you may wonder, why do we have 2 different strategies on a topic that's very similar and combined, actually, could be combined. So the plan is to combine those 2 strategies in 2 years, but we had the one first, and then we made another one, overarching health literacy strategy. So here we have different focus areas within those strategies, and now I'm going to deep dive a little bit more in the strategy we have for shared decision making. So it consists, we made a report with the evidence underneath this, so it's a 60-page paper with evidence, and so we had a lot of work here. So it consists of evidence-based recommendations, proposals and examples of measures to support the implementation of shared decision making in the specialist healthcare. And we have 4 areas of focus, and the goal was to strengthen the patient involvement in decisions. So the first area of focus is management level of ambition and organization. How many leaders are here today? Who is working in a leading position? Okay, good, some of you. So, and we know that this, of course, is very important when we try to implement something. So this is Norwegian. I'm just going to show you a bit how this works. So when it says RHF, this is a regional health authority, and this is for the hospitals. So we have 2 different, so it's built up like this, that this is actually my and my colleagues' plan, what we are going to work with the next couple of years, and this is for the hospitals. So here it says utarbeide en handlingsplan, so make local action plans for implementing shared decision making. So based on this strategy. So what is the status about that? So several of our hospitals have now developed own action plans, very much in line with this implementation strategy. And I'm going to show you a little example of that later. So the local action plans really use the same areas of focus, and they choose some measures like low-hanging fruits they want to start with the implementation in clinical practice. So this was just one example. I'm jumping to the next area of focus, and that is to increase employees' shared decision-making competence. And so here, on the regional health authority side, we have the aim to further develop and continue to evaluate modules within the Ready for Shared Decision Making framework. And now I'm going to jump a little bit out of this presentation and give you a little bit more deeper insight how we have worked with this. Because this was also a part of this project was my doctoral and PhD project. These are the logos. It was part of a larger project called the DA Factory. This project aimed to develop patient decision aids, and this is one way of trying to implement shared decision making, to develop patient decision aids. However, I wanted to look more into training healthcare professionals, and that's another side of the Rubik's Cube. You know what I mean? Yeah, so that you can see the logo. So the background, the methods, the implementation method we used for this project was the knowledge to action framework. Maybe some of you have heard about this. It's an implementation framework, and it has a knowledge funnel, how we synthesize knowledge, also to produce knowledge product. And one knowledge product could be a training module, as I provided to some of you yesterday. And then we have the action cycle around. And the action cycle includes 7 steps to facilitate a guided approach to implementation. So I'm not able to go deep into this now, but then we use this kind of implementation research for this project. So the background was that we identified a key barrier when we started working with shared decision making in Norway, and that was that healthcare professionals lack sufficient competencies in shared decision making. And there was no evaluated trainings available in Norway, meaning there was no systematic approach to increase these shared decision making competences. And we looked at international, we looked at the programs available, and we recognized that they're often targeted single professional groups, and it was mainly for physicians. They limited the interprofessional approach to shared decision making, which we now know it's very important to reach implementation. And they had also limited transparency in the content, and by that I mean when I looked at the trainings international, I was not able to recognize what are you actually doing within these trainings, and that was a problem. And also few had been rigorously evaluated, so we didn't know, do they actually have an effect in clinical practice? So there was a need for a unified training program to address these challenges. So that was why our primary goal was to develop a meta curriculum for training healthcare professionals in shared decision making. And we wanted it to be specialized to the specialist healthcare, since that's where I'm working, where we had this project, to target various target groups, not only physicians, but also nurses and combined groups, whole teams, different competencies levels, so we also could adjust the training to reach bachelor students like nurses, and to have an interprofessional approach to shared decision making. And we wanted to use a feedback-driven learning system, and that means that we are continuously evaluating and improving this meta curriculum. A stepwise development project guided by a known implementation research program, and of course evidence-informed and theory-driven. So, what is a meta curriculum, you might ask? So we have defined a meta curriculum to include, in this context, that it's not just one single training program, but it's more a modular toolkit that can be customized to different needs. So that includes multiple educational measures, such as training modules and learning materials. It defines the function and scope of each module, including the overlap and boundaries between the different modules. It holds the components together through a common didactic approach and this underlying theoretical framework, which I showed you earlier. And it also includes a system for adapting and developing these further components of training. So, and how does it look like? So here you can see we have a lot of different modules. So we target, here the target groups, so we target different groups. We have different kind of learning activities. Yesterday we used a lot of these different learning activities. We have different communication formats, so a podcast, skills training, we also have e-tutorials. And here you can see the different modules. And most importantly, one thing we soon realized that me and my few colleagues, we cannot go around and teach all of the staff we have in the hospital. So we really needed a trainer program to help and make it sustainable. So we have a trainer program where healthcare professionals attend these courses. They can look like this. Here we have a mixture between physicians and nurses and people working with patient education also. And they attend the trainer course. And then they are able to go out and to give this shared decision-making basic course to healthcare professionals at the different departments. So this was one important step to facilitate the implementation in the hospitals. So these trainers, they get access to a platform which we have developed, where they get access to a lot of different resources. So here we have different kinds of exercises, we have PowerPoint presentations, we have materials, handouts, and so on. So they can take this with them when they provide the training locally in their departments and at their hospitals. Here we have some trainers with a ready for shared decision-making bag, ready to go out and provide the training to the staff. So we have the different modules. We have evaluated them in several studies. We have the infrastructure by using this trainer course and have this network of instructors. And then we also have this regional implementation strategy to facilitate this kind of implementation. So what are the implications for practice? When we talk about practice in education, we see that the shared decision-making basic module, it has now been integrated in undergrad and postgraduate curricula all over Norway, actually, both for medical students, for nurses, for master classes, and the STM ambassadors, which we also call them, the instructors, they are continuing to improve and to provide this kind of training. And when we look at the policy, this trainer course and the Ready for STM framework is also referred to in our National Health and Hospital Plan. And several of our hospitals have now local action plans for STM training using training modules from this curricula. So here we can see that a lot of our universities, colleges, and hospitals have started to implement these different modules, and where we, in the modules, we implement this 6-step to shared decision-making model. So, for conclusion of this project of the trainings, we have different modules addressing various healthcare professionals. The training have been evaluated acceptable, and most have been feasible to deliver. We are still evaluating them and continuing to improve them. And the implementation is facilitated by this modular adaptive architecture, and we use this feedback-driven system. So when our instructors go out and provide the feedback, and then they can report back within a system and say, do you know what, I need some more slide about health literacy and shared decision-making and what the connection here is. And then we work on that together and make it available for all the instructors, to give you one example. And further evaluation is required to determine if this Ready for STM program actually will improve the quality of involvement in decisions, and as a part of this multifaceted strategy. Okay, so our hospitals, so one of our hospitals has made this local action plan for their, this is made especially for doctors in specialization. So they receive lynkurs, a very short course, for first a movie about what is shared decision making, then a short editorial, then a bigger editorial, and they can also take a podcast. And then they receive this STM basic course. And some of them also do this instructor course so they can provide the training to others. So just to give you an impression of how the hospitals have taken this into their plans. So back to this presentation. So the health authority developed regional competence requirements for the healthcare professionals, such as doctors and nurses. And then we developed these modules. And then the hospitals contribute to ensure that, that the healthcare professionals actually are taking these courses. So for instance, this one editorial for doctors, now this number is probably higher, but last time I checked, 2,700 doctors have taken this course. So to show you how the implementation is going. So to our next area of focus was to activate patients, because we know that is of course also very important. So one of the measures, we wanted to include a standard text about shared decision making in all our appointment letters. So our patients receive appointment letters in their digital platform, like digital inbox, and also on paper some. And here we now, it now says that be familiar with your rights as a patient, and that you have the right to participate in decisions about your care. And then they're guided to the national platform where they can read more about shared decision making. Another measure is to make available brochures and posters with 3 questions, which we know from research actually contribute to more shared decision making. So this is one of our posters with a new layout. And here our user board wanted also to not only have the 3 questions, but they also wanted to include what can we do as patients ourselves. So we found that was a very good thing. So we added now with the patients together, ask yourself how the different benefits and harms will affect your life. Ask yourself that as a patient, and think through what is most important to you. And one very important thing, of course, tell healthcare professionals what you have been thinking about. So we added this in the last version now. Also, one measure was to consider how shared decision making can be promoted, because a lot of our patients and our people in Norway actually don't know that they have the right to participate in healthcare decisions, right? Is it the same here in Iceland?
Yes.
Yeah. So, and that's why we wanted to also be, how can we promote it in the media? That's one important thing. So, one of our user boards made a campaign towards patients. Together we choose what's best for you. And there have also been a lot of different writing from patients to the public about this kind of involvement. And we have made a podcast together with a patient, which is available on Spotify and also on the hospital's web page and then different other sites. So, one other measure, some of you saw this yesterday in our training. This is a checklist to ensure the quality within patient information. So we have made that available also, because we know that our patient information in Norway is not good enough yet. So we want to contribute to this assessment of the healthcare information and to improve it. So this is just to show you one type of patient information about pain relief during childbirth. And this should have been, this kind of umbrella should have been green, so that women actually can make an informed decision with all the evidence and information they need. However, it's not green. So here we have a lot of quality improvement to work with. And all over, there's a new study coming, just a preprint is out now about the status of health information in Norway, and we have a lot of quality improvement to do here. So the last area of focus is supporting systems, to give you some insight what that means. In Norway, we have a lot of patient information on the hospital's web page. Here you can see one, it's for cancer treatment, and now we have been working very systematically to go through all patient information and implement these 3 questions about shared decision making within the patient information. So that can then lead to that patients come to us as healthcare professionals and ask these 3 questions. When they have received a diagnosis, then they actually ask, okay, what are my options? What are the different benefits and harms about these options? And then this will lead to more involvement. Another thing we do is to develop a patient decision aid app with the necessary information for patients about different treatments. So I want to the end just to come with some of our known barriers towards shared decision making. So we have this kind of barrier cards with a lot of nice color with different barriers. We meet a lot, both when I talk to leaders and when I talk to healthcare providers. And one of them is that my patients always ask me, what would you do? So what should we do then? Probably some of you recognize themselves. So the short answer here is to give the patient a reason for why they should participate, an invitation and a reason for why they should participate in the healthcare decisions. And to wait with giving them a strong recommendation for one treatment or another and give the balanced information first. Another one is this takes too much time. And we actually have some evidence on this. So from a big Cochrane review, we have evidence on this that showing that on average, it takes 1.5 minutes extra. That's not a lot of time, right? Other studies showing that you could actually reduce time spent. So evidence is not totally clear, but on average, if you use patient decision aids in the consultation, it might take 1.5 minutes extra. If you prepare them better, then you might actually reduce the time. So the short answer here is that shared decision making can lead to more appropriate use of resources, and it's a good investment in the patient's care pathway. The last one is we already do that. I hear that a lot actually. So, but we know that more and more patients prefer an active role in the decision-making process. This is a systematic review, some numbers from that. On average, this is also a new systematic review from 2024, and it says that on average 28% compliance with shared decision-making standards internationally. We have almost the same numbers in Norway. Hopefully you will do some similar studies in Iceland, so we know how the status is here. So what can we do when we say that we already do this? Because we know that there are often small changes and efforts to make an attempt to involvement, and it fails. And this could be, so if we recognize the situation where shared decision making is appropriate, that's the first thing that's important. So where can we use this kind of model? And providing complete and understandable information for the patients about the benefits and the harms, and holding back one's own recommendation until you have giving the patient the opportunity with balanced information and the opportunity to make up their own opinion about what is best for them. So I would like to end this lecture with a picture from 2 of our instructors. I asked them, what do you think is the best way to convince your colleagues to really conduct more shared decision making? And one of them said, I would go back and ask them, what if you had started a treatment and only afterwards found out that there were other options? So, in Norway, we had a lot of political support And it created wins in the sales when we started in 2012, and it was really a big help, I think, to get the implementation going. And I had, and we all had, the people working with shared decision making, we had to be patient, and that was a bit hard for me at the beginning, but I've also matured, and some patients may actually pay off, because then you get to do it rigorously and do it well. And we had to be ready to fight for some core principles in this concept. And of course, sharing and collaboration nationally and internationally is very important when we try to implement a kind of a new concept like this. So, I would like to open up if you have some questions or feedback. Are there some questions? Yeah. Or some feedback?
You can't do it in the dark.
No. We all became awake again.
Why did this start? Was there some impetus for starting this national project? It's really, really huge.
So why did it start? It probably started because we were working a lot with evidence-based medicine, evidence-based practice, and it was sort of launched out of that. The focus more on how to make good decisions with patients. And then the patient organization really bit onto that and found it interesting. And so that was how the first project started, yeah.
So more the patient were driving?
Yeah, there were some research projects, and then the patients were very much on board. And we were like a handful of researchers and healthcare professionals who had some projects and were really eager to pursue this. Yeah. Other questions? Yes?
Do you have any ways to measure the implementation?
Yes. So we have measurement tools. Internationally, we have a lot of different measurements tools. In Norway, we mainly use one. It's called the MAP-in SDM scale. And that's actually the same as the 6 steps we went through yesterday, but it's also a measurement tool on the behind. So you can measure shared decision making from healthcare professionals' viewpoint, from the patient as a questionnaire, and as an observer. So there are 3 scales in one actually. So you could use one of them or all combined.
Have there been any considerations about where the responsibility for the decision lies?
Yes, there has been discussions about that, and that is actually not changed even though we implement this, because the responsibility, they are actually clear in the law, right? And I think that's the same here in Iceland as well. So we have a responsibility as healthcare professionals to provide information to the patient so that they're able to make informed decision. And we are not trying to push the decision and the responsibility over to the patient by implementing this. So we should do this decision together and make it well informed, and not making the patient feel alone in the decision, but supported by the healthcare professionals. Other questions?
What about if the patient can't take a decision himself? Is the family member?
Yes. Very good question, of course. So if the patient, if it's an emergency situation or other reasons where the patient cannot participate in this process themselves, then of course relatives or patient nearby standing persons can in the same way proceed in this process with the healthcare providers. Yes. Okay. So you can always contact me if you have any further questions. Here's, yes?
Documents
In the journals? We had actually have a lot of discussions about that. Some of our hospitals want to be even. They want like that you can press a button and then we have the process of shared decision making coming up, and then you can write, okay, what are the options, what were the patient's preferences. And so some want that, and some say, no, this will take too much time for the clinicians. So we are actually having a discussion about that now. In Denmark, they are having a project, so they are having a pilot about it now, so I'm excited to see the results from them. In North Norway, they try to have like a button, did you include the patient in the decision, yes or no? But that doesn't actually work because everybody would press yes, right? So they have stopped doing that again. So we are looking, but some are actually doing it by nature, like they are writing when they write the medical notes, they write that the patient has been offered two options, we discuss them, and he chose that. Yeah. So some do it, probably here as well. Yeah.
But from the patient side, do you include it in the patient satisfactory service if they have been included?
Yeah, so we are just about to start implementing a new PREMS in our health region, and I'm actually responsible for that project as well. And there we are going to include some questions about how they've been involved and how the information was provided. So that will be interesting results from them because we have a lot of patients in our health region, so we'll get a lot of data. Yeah. And you also have some PREMS here, right? And do you have questions about the involvement? Does somebody know?
Yes.
Yes?
We have questions about the procedures, whether the patient was given information about the procedure,
Yeah,
the risks and benefits of it.
that's good.
Whether they understood the information they received. And also about discharge, whether the patient was informed about the discharge in advance and how was he able to participate in the decision to the extent that he wished to.
That sounds very good. So it's very good to have PREMS, you know, I really agree to that. The only disadvantage is that the response rate is so low in many countries. So in Norway it's about 30%. I know that internationally it's going like slowly downwards because they're getting like a feedback overload. Most patients, right? They're getting a lot of different, every time you go to in a store you get a feedback question. So that is actually a problem. So that's why we also do research projects to measure it from the patients, the healthcare professionals and the observer perspective, so we get some more valid information about it. But of course it's very good to have it in the large PREMS as well because it's an indicator, right? About this, yeah. Brynja.
Yeah. Can you tell us a little bit more about how hospitals have been introducing and integrating the curriculum into the, is it like obligatory? Do they have, how long time have they to do all these modules?
So all of our hospitals have now some of the modules implemented. And it started with the doctors because it was the easiest way to start implementing, because the doctors in specialization have like different programs they have to do with obligatory learning materials they have to go through. So as I showed you one example with these steps, that was for doctors in specializations they have to do to fulfill their specialization as a doctor. So then they have to tick the boxes. But now we also have these competency requirements for nurses available and other healthcare professionals. But we don't make it obligatory because we want the leaders at the different departments to do that, because we don't want to push them to do that. But some departments have done that for nurses and others as well. So it depends how eager and how they are. Yeah.
And it is a mixture of like self-learning,
yes.
watching podcasts or presentations,
yes.
and then sharing in groups?
Yes, so it's both classroom trainings, group exercises, and online tutorials. So that was the whole aim of this Ready for Shared Decision-Making framework, that we don't take them out for 3 days to have a communication training, because it's not feasible in practice, However, that they can combine different modules to build up, like the Bloom's taxonomy, to build their competences over time, so that they can put together different modules and increase their competences by doing different learning materials, yeah.
And would that take how long time if I was a nurse starting there?
So it depends how many of these you will take, but it could be some hours if you do, or it could be if you participate as a course that we had yesterday, like some e-tutorial and then 1 full day training and then some follow-up for some hours in 2 weeks later, for instance. Yeah.
And is the plan that you do it like regularly, or you update yourself?
Yes, and we also have like micro-learning, so which they talk about in the morning meetings at departments, just to don't forget about it, We tend to like do our practical stuff and then we are falling back into the old habits, but just to remind ourselves of practicing it. And then we also have the different brochures and stuff, and they are posted in the wards, and that's also a reminder, right? Yeah, and then if you document it in a journal, then we have to have these small reminders in a hectical clinical practice, yeah. Okay, I think I say thank you so much. I was very glad to be here.